Good evening, friends. A warm welcome to you, both the senior faculty, invited faculty, our own resident faculty, for joining us this evening for postgraduate clinics. We have invited faculty, Professor Mishra, Professor Nitin Nagpal, Professor Harindra Sadhu, and Professor Nag and Professor Sairam Subramaniam will be joining shortly. And we also want to welcome our own faculty, Dr. Rajiv Sahai sir, and other seniors here. I thank Dr. L. Sridhar sir from Apollo Medical College for kindly permitting Kairunisa to present the case today. Also thank Professor Karthik and Professor Karnakaran for kindly permitting Dr. Arun Prabhu to present the case of varicose veins today. Friends, this is our 266th edition of the postgraduate clinics. We are glad to keep going on every Friday. Those who wish to have information about regular classes, you can send a chat message to me. I will add up to the group. So good luck to both of the candidates. I request Dr. Ainunisa to introduce herself, our unit chief, head of the department, start a presentation. So the each cases have been allotted an hour. First half hour will be the clinical part, the history, clinical part, clinical finding. The second half hour will be for investigation, management, and complications. Good luck to both the candidates. Faculty, please take over. Dr. Kairunisa, we are not able to see a full screen. Yeah.
Yes.
Go to the first slide. Yeah, perfect. Good luck to you, Dr. Kairunisa.
Thank you, sir. Myself, Dr. Khairunisa Begum, a third-year general surgery resident from Apollo Medical College, Hyderabad. My head of the department and guide is Dr. L. Sridhar, sir, and Professor Dr. Fayaz Hussain, sir. Today, I'm going to present a case on obstructive jaundice. Should I start, sir?
Yes, please.
Please go ahead, Doctor.
Yes, please go on.
Thank you. A 58-year-old lady, housewife by occupation, residing in Hyderabad, belonging to low socioeconomic status, came to the surgery OPD with chief complaints of yellowish discoloration of eyes since 2 months, passage of high-colored urine since 2 months, itching all over the body since 2 months. History of present illness. Patient was apparently asymptomatic 2 months back when she noticed the passage of high-colored urine. Subsequently, her family members noticed yellowish discoloration of eyes, which was insidious in onset, gradually progressed for about 6 weeks. Then she had an episode of melena 2 weeks back, which lasted for about 3 to 4 days, following which there was diminution of yellowish discoloration for about 2 weeks, with subsequent increase of yellowish discoloration of eyes. History of passage of pale colored stool since 2 months. Complaints of itching all over the body since 2 months. History of loss of appetite, loss of unintentional and undocumented weight in the past 2 months, known by the loosening of the clothes. No history of prodromal symptoms preceding the onset of jaundice. No history of colicky pain and fever. No history of abdominal discomfort, distension, vomiting, or bleeding per rectum. No history of any bone pain, hemoptysis, visual disturbance, or backache. Past history, no history of similar complaints in the past. No known comorbidities such as hypertension, diabetes, hypothyroidism, tuberculosis, and COPD. Surgical history, no history of any endoscopy or any surgical intervention in the past. Personal history, diet mixed, sleep disturbed, bowel, bladder habit passing high-colored urine, bowel passing pale-colored stools, no addiction or any substance abuse. Menstrual and marital history, the patient attained menarche at 12 years of age, attained menopause at 47 years of age, is G3, G3, P3, L3, and A0, has 2 female and 1 male child with normal vaginal delivery. Family history, no history of jaundice or any malignancy-related deaths in the family. To summarize, a 58-year-old lady with known comorbidities presented with chief complaints of painless, waxing and waning type of jaundice and passage of high-colored urine since 2 months, associated with itching, pale-colored stools, loss of appetite and weight, with history of melena 2 weeks back, which lasted for 4 days, with no prodromal symptoms and signs of metastasis.
Okay. Dr. Merunisa.
Yes, sir.
Let's go to your first, Karunisa, sorry. Let's go
Yes.
to your first slide. I just want to correct you. It's monarchy, not monarch. Okay.
Oh.
Right. So you said low socioeconomic status. How do you decide that? How do you decide she's low socioeconomic?
By the annual income survey,
How much annual income do you consider as low socioeconomic?
less than 1 lakh per annum.
Offhand? Or are you sure about it?
I'm not sure about it.
Yes, that's why I want to tell you. Look, you just can't label someone like this without any evidence. It's
Okay.
not proper,
Okay.
right? More important would be if you have taken her social history, because if it's a case of malignancy, we want to know whether she can afford,
Yes.
if she has family support or not. All
Yes.
that is important. Okay. So all of this effect of the high colored urine, discoloration of eyes and itching happened 2 months back.
Yes.
For 2 months. It is not since, it is for. Since
Okay.
is when you know the date, for is for 2 months, for 5 months. Since
Okay.
would be from 1st of April, like that.
Okay.
Okay, next slide. Progressive. So why did you say by this history, what can you infer? That she had history of melena which then the jaundice, diminution of yellowish color. How did she find out that there's diminution of this jaundice? You wrote by diminution of yellowish discoloration for about 2 weeks. Is that so? Is that
Uh,
how a patient will tell you that the jaundice has come down? How do you decide about that?
Symptomatic. The patient says there's diminution of the discoloration of the yellowish discoloration. The eyes will come down, sir. Symptomatically,
As a surgeon, how do you decide whether there is the jaundice has come down?
clinically, sir.
Right, clinically what?
The by seeing the scleras or the yellowish
No,
discoloration.
no, no. The patient's appetite improves. There's a general sense of well-being, right? That is what. The discoloration doesn't come down so fast. You get me? And it's very difficult to judge.
Okay.
Okay, so what does that tell you? What do you infer? If the jaundice has come down, this
Uh,
is painless jaundice, isn't it?
yes, sir. Painless.
So what do you infer?
Any malignant pathology, sir. Obstructive jaundice due to some malignant pathology.
Okay, what kind of surgical obstructive jaundice? What are the types of obstructive jaundice of surgical?
Uh, Congenital, sir, or biliary atresia, choledochal cyst, inflammatory conditions like cholangitis, obstructive condition like
No, in
choledocholithiasis
this patient, I don't want you in this patient.
in this patient, sir. Since there is diminution, decrease in jaundice and with melena, sir, malignant pathology, sir, of the pancreas.
The pancreas. What are the types of uh, um, periampullary carcinoma? What are the types of uh, obstructive jaundice because of malignancy?
Malignant causes, sir.
Mm-hmm.
Periampullary carcinoma, the carcinoma head of the pancreas, cholangiocarcinoma,
So
carcinoma
they
gallbladder.
all come under periampullary carcinomas, no? What do you mean by periampullary carcinoma?
So within 2 centimeter of the ampulla, sir, it includes ampullary variant of periampullary carcinoma, carcinoma
Mm-hmm.
head of the pancreas, duodenal carcinoma, and distal cholangiocarcinoma.
Right. So what do you think this this is characteristic of which type of periampullary carcinoma?
Ampullary variant of periampullary carcinoma.
Ampullary variant. Very good. So how common is ampullary variant?
Um, I do. Overall
It's very
adenocarcinoma.
rare. It's very rare. It's very rare. 4 to 5 per million,
Okay.
right? So it's very rare, right? Okay. Uh, pale colored stools, dark urine. Okay. Next slide, please. Which prodromal symptoms are you looking for preceding onset of jaundice?
So, fever, pain, malaise.
Okay. No history of abdominal discomfort, distension, vomiting, bleeding per rectum. You said there is melena.
Yes, sir.
Is melena type of bleeding per rectum?
Uh, Bleeding per rectum, frank blood
You mean
loss.
fresh blood?
Yes, right.
So you should just qualify that, right?
Okay.
And don't write history, no history of bone pain, hemoptysis. You can't list out all the features of second metastasis. Just say no history suggestive of distant metastasis.
Okay.
Right. Next slide, please. Similar complaints. Okay. Comorbidities, surgical history. Okay. Next slide. Okay. Next. Uh, any important family history? If you have a patient of periampullary carcinoma,
Sir, I would like to ask about any histories of breast cancer, ovarian cancers, or colorectal cancers in the family.
specifically which ones? What about HNPCC or FAP?
Yes, sir.
Are they
Fam-
related to this or not?
yes, sir. Familial adenomatous polyposis and Lynch syndrome is associated. Is
So
anything
how do you take the history for that?
uh, any history of cancers, colorectal cancers?
Now, what did you ask about family history? How did you ask the patient? What question did you put forward?
Uh, Patient, any family members having any abdominal pathology for which they were treated or operated, or any past deaths due to any cancers,
How does the patient of FAP usually present with?
skin conditions, or um,
FAP will present
bowel,
with skin condition.
altered bowel habits, and
Right. There'll be history of bleeding per rectum or
correct.
melena. They start off with that. There can be signs of obstruction, intersusception, all that kind of thing. Okay. Next slide, please. Okay, next. So what's your differential or what's your diagnosis, probable diagnosis on history?
Obstructive jaundice due to malignant pathology.
That's it. First of all, it's not obstructive jaundice. You say surgical obstructive jaundice. What's surgical obstructive jaundice? What is
Uh,
SOJ?
Jaundice that obstructive jaundice that can be treated with surgical treatments.
Can be treated only by surgery. That's right. Very good. So this is surgical obstructive, probably due to what? Malignancy where?
Ampullary, sir. Ampullary.
Periampullary. You want periampullary. You just can't come out in ampullary. Okay. So by your history, can you rule out the other three periampullary carcinomas just by history?
For carcinoma head of the pancreas, so there'll be progressive jaundice. There'll be no waxing and waning type will not be seen, sir. And
Anything else? Carcinoma head of pancreas will present anything in any other way?
melena history will not be there.
There can be. When
Uh,
can a carcinoma head of pancreas present with melena or bleeding per rectum?
Advanced case.
Advanced where? When it involves the duodenum. When it infiltrates into the duodenum, it'll cause ulceration, ulcerative proliferative growth there, or
Yes.
duodenal carcinoma.
Yes.
CA duodenum presents usually how? How do the patients of CA duodenum present?
Uh, Obstructive, the vomitings.
Right.
Yes.
Gastric outlet obstructions.
Gastric outlet.
Right. Right. Okay. So anyone else?
Dr. Karunisha, you asked for the history of endoscopy. What do you mean to ask by that?
I want to rule out any biliary stricture, pathology, sir, for which
Like,
patient has undergone, if there was any biliary stricture for which patient has undergone stenting or any for stones, common bile duct stones, for which patient has undergone stenting.
how will that be related to your case? You are taking the history in terms of your patient only, na?
Yes.
So what you want to correlate with that?
To differentiate to rule out other causes of obstructive jaundice.
Isn't it that you want to rule out portal hypertension in the patient?
Yes, sir.
Okay. What is the most common variant in the periampullary carcinoma? Periampullary carcinoma is not one cancer, na?
Yes, sir.
So what is the
Carcinoma
most
head of
common out
the
of that? Pardon?
carcinoma head of the pancreas, sir.
So why don't you think that this can be carcinoma head of the pancreas? What are the points in the history which are against the carcinoma head of the pancreas?
Um, to start with, age, sir, gender, there's no smoking and alcohol history, uh, and progressive jaundice. This is not a progressive.
What is the classical presentation for carcinoma head of the pancreas?
Elderly male, sir, with smoking and alcohol history, diabetes, early new onset of diabetes mellitus, and
So
painless
it's painless progressive jaundice in an elderly male patient. Okay.
elderly male patient.
So your jaundice is not progressive. Okay.
Yes.
Oh, okay. Please go ahead.
Karunisha, what is the difference between a waxing waning jaundice and intermittent jaundice?
So waxing and waning jaundice, it improves symptomatically, but the bilirubin level will not touch the baseline, sir. In intermittent jaundice, touches the baseline, sir.
So can you give the causes for the intermittent jaundice and causes for the waxing waning jaundice?
Malignant causes, sir.
Any cause, yeah.
Intermittent, sir, in polydocylithiasis, in
Yes.
um, cholangiocarcinoma.
In periampullary carcinoma, is it an intermittent type or it's a waxing waning type?
Ampullary variant is waxing and waning type. Sir. This can also present intermittent.
It will be never intermittent, isn't it? It will never touch the normal level. Okay, whatever the type of the periampullary carcinoma is there, it will be only a waxing waning variety, not the intermittent variety. Now, what is the difference between a periampullary carcinoma and a carcinoma head of pancreas?
Clinically,
Location wise, yeah. What is the difference? When you say it is a periampullary carcinoma and when you say it's a carcinoma head of the pancreas, because you are telling about the carcinoma head of pancreas. So, what is the difference between these two?
periampullary is within 2 centimeter of the ampulla. The structures are involved just
So
within.
even if it is involving the head of the pancreas, but it is within 2 centimeters of the ampulla, that will be called as periampullary carcinoma. Okay. If it is beyond that, then that will be called as carcinoma head of the pancreas.
Yes.
If there is a massive bleeding is there per rectum, what is that called as?
Hematochezia.
Hematochezia. Yes. Now, how do you clinically differentiate that whether it is a medical cause for the jaundice or a surgical cause for the jaundice? Clinical differentiation. Yeah.
Clinically, sir, pale colored stools will not be there, sir. Painless jaundice, progressive jaundice, painless, it will not be there.
What is the most important thing to differentiate whether it is a surgical jaundice or a medical jaundice? Symptoms wise only, yeah.
Urines, high, it will not be high colored urine. Pale colored stools will not be there if it is a medical jaundice.
prodromal symptoms which are
Prodromal.
there. Okay. So that is the most important thing. That if the patient has a prodromal symptom, it is likely to be a medical jaundice. If the prodromal symptoms are not there, it is likely to be surgical jaundice. So can you tell the jaundice because of the medical jaundice? Obstructive jaundice because of the medical jaundice? Obstructive jaundice because of the medical jaundice.
Parasitic infestation.
Okay, something simple, which occurs if you do not properly treat. If any type of viral hepatitis is there, what can happen? Which can lead to a type of the obstructive jaundice, not the surgical jaundice, but the obstructive jaundice. What is that called as?
Because of
Cholestatic variety. Yeah,
cholestasis.
cholestatic variety of the medical jaundice can lead to a surgical, not the surgical jaundice, obstructive jaundice. Okay. Okay.
Any history of chronic drug intake in this patient?
No, sir. No.
Can you name some cholestatic drugs?
Rifampicin, antitubercular drug, rifampicin, sir. Valproate, methyl dopa, halothane.
So can you tell the drugs which causes the urine yellow colored? The commonest drug which causes the urine yellow colored.
Antitubercular drug.
Commonest drug.
Commonest, which is there. Commonest drug used by almost taking at the counter.
No idea.
Simple B complex,
B complex.
Yeah, anyone takes the B complex and that will cause the urine yellow.
Yes.
So how do you differentiate this yellow color urine which is there is because of the drug or it is because of your jaundice?
Clinically, sir.
Do not look at the first sample which is there, okay, of the urine. First sample, even in the normal persons, it may be slightly yellow.
Okay.
Okay. And if the patient is taking the B complex, it will be definitely yellow.
Okay.
So always see those samples later on, whether there any change in the color or not. Okay. In the normal situation of patient taking the B complex, this will become lighter. Okay. More of the whitish urine rather than the colored urine. Okay, so simple B complex is the commonest cause for the yellow colored urine. Okay.
Okay. So, Dr. Karani sir, why do you think your patient is having itching?
Because of increased bile salts in the circulation, sir, which get deposited in the skin, and
Where do they get deposited?
the subcutaneous layer, sir, irritation of the nerves.
Subcutaneous. Subcutaneous. Yes.
Yes.
I mean, where in the skin? The subcutaneous tissue is not a part of the skin.
In the dermal layer.
Yes, in the dermal layer. Now, what do they do?
Irritation of the nerve ending, sir, and also stimulate the histaminic reactions.
And produce what?
Mast cells, sir.
Okay. Yes. Yes. Any other skin changes you expect in such kind of patients? Some skin manifestation you expect? probably due to deficiency of some vitamin.
Dermatitis,
Dermatitis. No.
nutritional deficiency.
Deficiency of what should happen due to obstructive. Well, what all nutritional deficiencies can occur due to,
Fat-soluble vitamins will not be absorbed. So
and which of them will manifest first among the fats? What are the
vitamin
what
A.
are the vitamin A? So what changes should happen with vitamin A? So what are the vitamins? Can you name the fat soluble vitamins?
Vitamin A, D, and E, sir.
E and another one.
A and vitamin D, sir.
And what's your name?
Ferronis.
What's your
Vitamin
ah,
K.
okay. So among A, D, E, K, which will manifest first? What deficiency will manifest first?
Vitamin K, sir.
Yes, yes. How should it manifest?
Bleeding increase in.
When some patient is itching, okay, there can be, and there is vitamin K deficiency. So clinically, what will be the presentation?
Purpuric spots.
Yes, petty K, purpura, yes.
Purpuric.
You have to ask the history of those manifestations.
Okay.
Rest of the things have been very well covered by my colleagues. I think Dr. Rajiv, if you can move on to examination.
How the vitamin A deficiency presents?
Yes.
Eye manifestation, sir.
In what form?
Night blindness, sir.
Night blind. Okay. So you should also take the history of that. In about 10% cases of obstructive jaundice, surgical jaundice, you can have the night blindness. Okay. Yeah. I think you can go on the examination now.
Okay. General examination. Patient is conscious, coherent, cooperative, and oriented time, place, and person. Icterus present. No edema, cyanosis, clubbing, generalized lymphadenopathy noted. Patient is average built and nourished. BMI is 19.23. Hydration status educate. Karnofsky performance status 90. ECOG score is 1. Vitals, patient is afebrile. Pulse 78 beats per minute in right radial artery, normal volume. Blood pressure 120 by 80 mm mercury in right arm in supine position. Respiratory rate 18 cycles per minute. Saturation 97% on room air. Local examination per abdomen. An inspection, patient is examined with informed consent in supine position, arms by the side, and exposed from mid chest to mid thigh with genitalia covered. On inspection, the shape and contour of the abdomen appears normal. Umbilicus is centrally placed and inverted. Fullness noted in right hypochondriac region. No visible dilatation of veins, scars, or visible peristalsis noted. All quadrants move equally with respiration. No visible peristalsis or pulsatile movements. Hernial orifice, no impulse on cough noted. External genitalia appears normal. Palpation, no local rise of temperature, no tenderness present. Gallbladder is palpable below the right costal margin, size around 4 into 3 centimeters, smooth surface, moves with respiration with upper margin not palpable. Liver and spleen are not palpable. Renal angle, no tenderness. External genitalia normal. Left supraclavicular node not palpable. On percussion, dull note is present over the lump. Rest of the abdomen, tympanic note is present. No shifting dullness noted. On auscultation, bowel sounds are heard. Per rectal examination, external anal tone normal. Rectal mucosa freely mobile. No growth or deposits present. Finger fecal staining present with no blood stain noted. Per vaginal examination, anteverted uterus and fornix is free and mobile. Systemic examination, cardiovascular system, S1, S2 heard. Respiratory bilateral air entry present with no added sounds. Central nervous system, motor and sensory examination within normal limits. To summarize, a 58-year female presented with painless jaundice with waxing and waning and high-colored urine since 2 months, associated with passage of pale-colored stools, itching all over the body, with history of melena 2 weeks back, which lasted for about 3 to 4 days, with loss of appetite and weight and no prodromal symptoms. On examination, patient is icteric and palpable gallbladder with no palpable left supraclavicular node.
Karunisha, why did you say about Karnofsky status and the ECOG both?
Performance, sir, whether because of the existing symptoms and signs and symptoms, patient is able to carry out normal activities. To know.
No, both are for the performance status. So why you're telling both, or when you should tell about the Karnofsky and when you should tell about the ECOG?
Earlier, they were used for assessment for the chemotherapy, sir, for the start of chemotherapy, and to know the fitness for surgery and to assess the patient's status. Sir.
ECOG only for the malignancy.
Okay.
Okay, you are suspecting very strongly that there's a malignancy is there. Then you will tell about because this is basically for the cancer.
Yes.
Okay, what is ECOG? What is ECOG? It is Eastern Cooperative Oncology Group.
Oncology
okay, so it is only for the oncology person. You know? Karnofsky can be for both benign as well as the malignant condition. Okay. So if you say the Karnofsky, because still we are not sure, are you dealing with a malignant case or it is a benign case? Okay. So Karnofsky will be good here. Then you said all quadrants are moving equally with the respiration. Is that a correct statement? All quadrants cannot move equally with the respiration. No?
Yes.
So you just say proportionality rather than equally.
Okay.
And did you look for the lever span in your patient?
Yes, sir.
Where did you mention that lever span?
I forgot to mention. Lever span normal.
So where do you measure the lever span?
By percussion method, sir. We start percussing in the mid-clavicular line, the coastal spacer, and percuss down. Then at the point where we feel the dullness, from there we measure till the continue the dullness, sir.
But in your patient, what will be there when you are percussing at the mid-clavicular line here?
Liver dullness is mostly start with fifth intercostal spacer, and the dullness will continue with the gallbladder.
The gallbladder will be there.
Yes,
will you be able to measure that in the mid-clavicular line?
No, sir.
So then what should be done? Yeah, normally you should measure it in the mid-clavicular line. Okay. But if there's a lump is there in that area, you cannot measure that.
Yes, sir. We have to move towards the mid-axillary.
Yes. You have to go to the anterior axillary first. And still if it is there, then you may go to the mid-axillary. Okay. But in this, your patient, because the gallbladder lump will be there, you can't be measuring the lever span in that mid-clavicular line. There you have to go to the anterior axillary line.
Yes.
Then you said the external genitalia is normal in a female patient.
Yes.
So do you mention about in a female patient the external genitalia? It is not a good practice, no? In a female patient to say external genitalia is normal is not a good practice.
Okay.
In the males, it is okay.
Okay.
And did you tell about the ascites in your patient?
Shifting dullness, yes, sir.
So ascites, I said the ascites. So it is only the shifting dullness or?
No free fluid.
Yeah, so better to say there is no free fluid. You know?
Okay.
rather than saying, because what are the various ways to elicit the ascites? Clinical ways?
Clinically, sir, by fluid thrill method, sir, and by palpatory method, sir.
How will you palpate the ascites?
Sorry, percussion method, sir.
You're telling one is the shifting dullness, second is the fluid thrill.
Fluid thrill,
Any other
sir.
way to know about the ascites? You may say that you can do it by ultrasound, but clinically we're asking. Clinically, if there's a minimal fluid is there, how do you do that?
By turning the patient to the lateral one side of
So that is the one or in the knee elbow position.
knee
That is
elbow
not a
position.
good position. But if you want to elicit the minimal fluid,
You have to do knee elbow position.
yeah, you can go for that. So these are various ways to. So rather than just saying no shifting dullness, no clinical evidence of ascites.
Okay.
Okay. Okay.
You have not told us about gallbladder lump. What is the consistency of this lump? Go back. You have not told about the consistency of this lump.
Yes, sir.
So what should we think about the consistency? So this is the only lump you are able to palpate in the abdomen, no?
Yes, sir.
There is no other significant finding. Firstly, why you say this is a gallbladder lump?
Sir, because it is just below the right coastal margin, sir, and it is moving with respiration, sir, and the dullness over the lump is continuous with the liver dullness.
Okay, so what was the consistency? Do you remember that? Will that matter?
Yes, sir.
That can make a significant difference in your case, isn't it?
Yes, sir.
So what, having said that you are dealing with the patient you are thinking in line, so what type of gallbladder lump you expect to be? What should be the consistency?
Oh,
You are thinking in terms of periampullary cancer, no?
yes, sir.
So a gallbladder lump in a periampullary cancer should be of what consistency?
Tenth.
It will not be hard, no?
Yes, sir.
It will not be hard in consistency. Okay.
What is the classical description? Classical description of, sorry, please, Professor, go on.
What is the Courvoisier's law?
So, in a patient with jaundice, if the gallbladder is palpable, then it is not due to stones, sir.
In a patient with jaundice, if a gallbladder is not palpable, it is unlikely
If
to
gallbladder is palpable, it is seldom due to stones, sir.
Okay, what are the exceptions to the gallbladder? What is the exceptions to this?
Double impacted stone, sir. If the stone is there in the common bile duct and also in the cystic duct, sir. If it is mucocele or empyema of the gallbladder.
So please, Nitin sir.
So, Dr. Khairani sir, can you go to the slide of general examination? General examination. So, what do you think is the significant for affliction among vitals? What should be affected in the cases of obstructive jaundice?
Icterus or icterus is present.
Among vital signs,
pulse, sir.
Pulse, what should happen to the pulse?
Bradycardia, sir.
Okay, why should that happen?
Because of the deposition of the bile salts in the SA and AV nodes, sir, and because of the vasovagal effect.
Okay. And do you think your general examination is complete? What is missing? When we are talking about jaundice, what are the things you should talk about? What are the signs of liver cell failure? Isn't that important?
Yes, sir. Yes.
You told your patient is having itching. Isn't talking about scratch marks important?
Yes, sir. But patient didn't had scratch marks, sir.
You should, you should that becomes a negative history of positive importance. You give her the history of itching, then history of petechiae purpura, liver cell failure. All this history should, all this examination, general examination, head to toe should be mentioned.
Okay.
Okay.
Yes.
Mhm. So, and what is the classical description of a gallbladder mass when we are talking about obstructive jaundice?
Mm, distended gallbladder with smooth surface, sir, which moves with respiration.
The moves with respiration. The three classical things which describe is a number one, soft.
Oh, yes.
Second, globular. The shape which, okay, from the globular shape itself, you will differentiate from many other swellings. They'll give you that it's a soft, globular, and moving with respiration. These are three classical signs, and out of the three, two are missing within your description. Okay, so that the classical, it's for the sake of other participants, a soft globular mass which is moving with respiration points out to a diagnosis of a gallbladder enlargement. Okay, yes. I'll pass on to my other colleagues.
Yeah, Dr. Therunisa, I'd just like to tell you two things.
Yes.
One, it is not hypochondriac. It's hypochondriac means someone who's always worried about falling sick, hypochondrium.
Yeah.
And what do you mean by external anal tone? It's just anal tone.
Okay.
You think there's no internal anal tone?
It is there.
Internal sphincter doesn't have a tone,
It's there, sir.
right? Yeah, so just correct with
Yeah.
that. So how do you
And
proceed now? Sorry.
sir, sorry,
Go on.
just yes, sir. Regarding the finger fecal staining, something else you mentioned in history, and it is not corroborating with your history. So probably the history has been casted sitting. Okay, even the examination is written, I think, sitting at your home because it is not corroborating. You classically have made the history of a obstructive jaundice with a distended gallbladder, and your finger staining is of feculent color with no blood.
Oh,
Okay, it is not corroborating with your history.
okay.
Okay, you have to be careful.
Okay.
You have to present whether did you do a rectal examination. I think from this it's clear that you have not done a rectal examination.
Yes.
Did you do a rectal examination?
Yes, sir. When
Yes,
patient presented, sir, that time a patient was not having melena, sir.
not having.
Yes, sir.
Okay. And what deposits are you looking for
Um,
on
met-
rectal? Huh?
metastatic deposits, sir, or
Where? Where?
in a pouch of Douglas,
Okay. What are they known as?
a Blummer shell,
Blummer cells. And what is the mechanism of metastasis getting there?
peritoneal spread, sir.
Peritoneal or trans,
Coelomic.
transcelomic. Okay. So your history and the rectal findings are not corroborating. Okay. The examiner can find the fault there. Okay.
Okay.
So you have to be careful.
Okay.
Mhm. And classically in history, when the patient is having clay-colored stools with melena, what color do you expect?
Silver stain, sir.
Silver stain. The classical description should have been silvery, but sometimes the melena is massive and it will overpower the. But classically, with waxing and veining, you get a silvery stools rather than melena color.
Yes.
So, what is the classical clinical description of a melena?
Black tarry smooth.
Black tarry stools which stick to the
Stick to the
pan. That is the classical description. Okay. Yes. Okay. Go ahead. Dr. G, sir, please.
Okay. How do you manage this case now? The patients come to your OPD with these findings. How do you proceed?
I would like to proceed with liver function test, sir, and
Okay.
ultrasound abdomen and pelvis, sir.
Just liver function test. No other blood tests.
Yes, sir. Complete blood picture, routine
What
blood
are, what are you looking for in CBC?
for anemia, sir,
Right. Anything else?
and for the TLC count, sir.
Okay. Very good. Why PLC count?
For any infective.
Of course, infection. But why? Why do you think a patient of obstructive jaundice is looking for infection?
Mm, sepsis, sir. Uh,
Mm, okay. Jaundice patients are prone to infection,
mm,
right? Because of suppression of immunity,
mm,
right? Also, the stasis of bile,
yes.
isn't it? Which is
Yes.
a good media for infection, right? What else? LFT, what are you looking for?
Looking for the total bilirubin and conjugated bilirubin, direct bilirubin, sir.
What do you mean by conjugated bilirubin?
Uh, Bilirubin in the liver when it gets conjugated with glucuronic acid. So earlier it is water insoluble, it becomes water soluble by conjugation.
So how do you test? What is the test for conjugated bilirubin?
Direct
What's the
bilirubin.
name of the test? It's a Vandenberg test. Okay. Do you know about that Vandenberg test?
Yes, sir.
Yeah. Okay.
Mhm.
What else are you looking for in LFT?
The enzymes, sir, ALP and GGT, sir, and for
More importantly, more importantly,
ALP and GGT, sir, and, serum albumin, sir.
serum
Albumin, sir.
albumin. Okay. Anything else? More important.
PTINR and prothrombin.
Okay. PTNR. That's also nice. That's for coagulation profile. What about alkaline phosphatase?
This is ALP, yes, sir.
ALP. Okay. So, what are the other sources of increased ALP? Other causes?
Bone pathology, sir.
So, can you distinguish alkaline phosphatase of bony origin from alkaline phosphatase liver origin?
Alkaline phosphatase we cannot differentiate, but if we can differentiate by doing GGT and 5 alpha reductase.
No. My question is, can the alpha alkaline phosphatase of bone origin be differentiated from alkaline phosphatase of liver origin?
No idea. I don't know. I don't think we can differentiate.
Well, this is bone alkaline phosphatase is found to be more heat labile,
Okay.
right? When you heat it, it breaks down. Okay, what else are you looking for? What other blood tests are you looking for?
Yes, sir.
What other blood tests are you looking for? You've done your CBC, you've done
Just
your LFT.
LFT albumin, sir, albumin levels, PTINR level.
Yeah, we're done with that. Anything else? Any other blood tests? You spoke something about recent onset of diabetes. So
Diabetes,
get a blood sugar done.
yeah, blood sugar levels.
Anything else?
Sorry to interrupt you, sir. Uh, I'll just connect my laptop to a charger, sir.
Please do. Please do.
Sorry, sir.
Oh, she's disappeared. Yeah. Yes, all set?
Really
Yeah.
sorry, sir.
No, that's fine. What about KFT?
Yes, sir. I would like
Yes,
to.
sir, what?
I would
How
like
is
to.
KFT related to this?
Yeah, yes, sir. I want to know the creatinine and the
How is it related to your case?
uh, it can it can lead to renal failure, sir. Hepatorenal syndrome.
What is that? Hepatorenal syndrome.
Decreased GFR, sir. Decreased urine output.
Come again? Okay. So why does that happen?
Because of the deposition of the biles or in the glomerulus, sir.
Well, that was one theory, but more importantly, that there are toxins which damage the epithelium. Okay, right. Any other tests? Look, Dr. Karinisa, you got to divide your investigations into investigations to confirm your diagnosis, right?
Yes, sir.
To stage the disease, all that kind of thing.
Yes, sir. I would
So, how do you confirm the diagnosis? What is the first investigation? All this is fine. Blood tests are
ultrasound,
fine.
ultrasound abdomen and pelvis, sir.
So, you do an ultrasound. What are you looking for in ultrasound?
We're looking for the gallbladder pathology, sir, in CBD status, sir, and for intrahepatic biliary.
What do you mean by CBD status? What do you mean by CBD status?
Common bile duct dilatation if there, sir, if any stone, sir. Dilatation of CBD, I want to see, sir. And I want to see if pancreatic lesion if possible.
Okay.
And to confirm the diagnosis, I would like to go ahead with contrast enhanced CT scan, sir. Pancreatic protocol CT, sir.
Okay, pancreatic protocol. Why? What is pancreatic protocol?
We take the three phases CT, sir. Early arterial, late arterial, and portovenous phase. Sir. A late arterial phase is a pancreatic phase, sir.
What is the contrast used?
Iodinated contrast, sir.
That's it.
Yes.
Any intraluminal contrast?
No.
Use water.
Oh.
Right, fluid water.
Yes, sir.
So anyone else, please.
Karan, how do you differentiate on ultrasound whether it is a medical jaundice or a surgical jaundice?
Dilatation of the intrahepatic biliary system, sir, and dilatation of common bile duct. And if it is any pancreatic lesion, if seen on ultrasound.
So if there is a Klatskin tumor is there, will there be dilated bile duct?
No, no, sir.
So your answer should be only that if there is an intrahepatic biliary ductal dilatation is there, it is likely to be a surgical jaundice or a obstructive jaundice. If it is not there, it is more likely medical jaundice. Ultrasound should be the first investigation before you go for the blood investigation, because that is going to give you the diagnosis.
Yes, sir.
Okay. So in a patient who is a jaundice patient is there, it's almost going to give you the diagnosis.
Okay.
Now, what is the most confirmatory test on ultrasound to say it is a carcinoma head of pancreas or periampullary carcinoma?
Double duct signs.
Yes, double duct sign is very important. So in a elderly, especially male patient, okay, if elderly male patient is there and you find a double duct sign, it is almost confirmatory that you are dealing with a carcinoma head of pancreas.
Yes.
Okay. What are the other things before you go for the CT scan in a patient of your obstructive jaundice, where you may not have to do the CT scan, which you can see by the ultrasound? If you find the multiple liver metastasis is there,
yes.
okay,
Yes,
so probably the CT scan may not be of any help in that patient.
Yes, sir.
You can only get away only with the ultrasound.
Yes.
So it is not always necessary to go for the CT scan, Jay.
Okay.
Right. So after the ultrasound you have done, what will be the next investigation? You ask about the alkaline phosphatase, no?
Yes.
What are the places from where the alkaline phosphatase is produced?
The biliary system, sir, bone.
Not the biliary system, it is from the liver, no? From the liver and
Bones.
and
Intestines.
intestine, yes. And
Kidney,
in the females,
um,
young female,
ovaries.
placenta. Okay, it can be also secreted with the placenta. And you can carry out various type of the what are called isoenzymes for the alkaline phosphatase. By that, you can differentiate between these varieties of that which type of the alkaline phosphatase is raised or not.
Okay.
Okay. Then you have done the ultrasound, you have done the CT scan. What other investigation you want to do? Investigation in any case is first is to make a diagnosis.
Yes, sir. Then to.
Second is to stage the disease if it is malignant.
Yes.
And third is investigations to treat the patient. So what are the investigations here to make the diagnosis? One you said is the ultrasound.
CT.
Yes, CT. Any other investigation which can confirm that it is malignancy?
Endoscopic ultrasonography, sir, for biopsy, sir.
How do you take the biopsy of a pancreatic malignancy? What are the various ways to take a biopsy of the pancreatic malignancy?
Brush cytology and ampullary.
Yes. Can you do any guided biopsies? One you said is the
CT guided.
yes, CT guided, yes. Endo ultrasound.
Endoscopy, yes.
You told about that endo ultrasound.
Yes.
You can go for a cytology or the biopsy from that. No?
Yes.
Any other investigations? Once you have confirmed it, will you like to stage your patient?
With the CT, so I can stage the
CT, what are the things you see in the CT scan?
we can see the location and extent of the disease, sir, involvement of the vascular and lymphovascular system, sir.
Okay, it's the same as the TNM.
TNM, yes, sir. Distant
Okay.
microstage.
T is for the tumor.
Tumor,
To
node,
see further what is the location, site of the tumor, what is the size of the tumor, what is the involvement of the various structures surrounding that.
Yes, sir.
Then second is the nodes, you have to see for the nodes. And third, you have to see for if the patient has got the liver mets or not, or ascites is there, peritoneal nodules are there.
Yes.
Okay, so same in the way you have to go over the TNM staging. No? Right. Any tumor markers you want to do?
CA 19.9, sir. CA.
Yes. Okay. Then third set of investigations in the patient who has got the jaundice. What are the third set of investigations? Is your liver function test is the most important. The renal function test,
Yes.
Apart from all the CBCs, and it has to be done.
Yes.
Now, in the liver function test, what is the most important test which can change your treatment?
Albumin also.
Yes, the albumin is almost. Yes. Anything else? What about the bilirubin? How does that change the treatment?
Conjugate.
Should we do the preoperative drainage or not? How it is that is decided?
If If the patient is, it is a resectable disease, sir, then no need for any preoperative drainage procedure, sir.
Yes. Yeah, it's a very debatable thing, but still, if the bilirubin level is more than 15 to 20, you can go for the preoperative drainage. But you're right, that if the resectable disease is there, you should resect it as the earliest rather than draining. What is the problems with the drainage?
Infections or the fibrosis.
To the surgeon's technique, what is the problem? If it is stented,
And fibrosis will happen, sir, around
of
the.
inflammation is there, and the fibrosis may be there, and that sometimes technically becomes very difficult to work around the bile duct.
Yes.
Okay.
Okay, Dr. Kennedy, sir. Uh, what about now you've seen this, you've diagnosed this patient, you've done all the investigations.
Yes.
Now, what do you do? The patient is in a ward. What treatment do you start?
So before, if it is a resectable disease, sir, before taking for surgery, I want to optimize the patient, sir.
Very good. How do you do that?
By preoperative preparation, by stabilizing any anemia, by correction of anemia, sir, to increase at least
Very
more
good.
than 10 gram percent, sir. By
Okay.
replenishing the glycogen reserves, by giving carbohydrate rich diet.
And suppose the
And
patient is diabetic, then
um, still, sir, we can. I'll try to maintain the glucose level in between 100 to 150.
okay.
By
So you still give high carbohydrate diet.
try
Any
to
more?
maintain
Anything important about it other
along
than
with
that?
insulin correction, sir. I'll
Okay.
try to
Anything
maintain
else?
the
Okay,
between
go on, go on. What else?
correct the nutrition hydration status, sir. With chances of renal
Yes.
failure, the hydration,
So you hydrate the patient. How do you hydrate the patient? How do you monitor that the patient is hydrated?
urine output, sir.
How much is the minimum urine output required here?
0.5 to 1 ml per hour, sir.
Okay, good. What else?
Then vitamin supplementation, vitamin K, sir, to improve the prothrombin and PTINR, sir.
Okay,
There's chances of gram-negative septicemia, sir. So I would like to start with broad-spectrum antibiotics
very good.
and pulmonary physiotherapy, sir.
Okay. So you've done all this, right?
Yes.
Now, how do you decide whether the patient is operable or not?
Based on the CT findings, we'll classify into resectable and
Okay. What are the findings which tell you that it's resectable?
if the tumor
Or
is
tell us what are the findings, what are the indications of non-resectability?
liver and peritoneal metastasis, sir. Presence of
So will your CT pick up peritoneal mets?
no, sir. Liver mets can pick up ascites, sir.
So if there's no ascites, or okay, ascites could be because of hepatic failure,
Yes.
insufficiency. How do you know it's because of mets in the peritoneal cavity? How can you pick up mets in the peritoneal cavity? By laparoscopy.
Okay.
Okay.
That is a laparoscopy. That is.
So anyone else? Okay. So one is that. What are the other features of non-resectability?
The presence of lymph nodes beyond the field of resection, sir,
And what's that?
involving the pariotic, pyloric lymph nodes, sir, and
Some
involve
more precise things.
Mm,
Come to some more precise things.
involve celiac axis or hepatic artery.
Hepatic artery.
Liver nodes.
Anything related with superior mesentery?
Yes, involvement of superior mesenteric arteries.
How much?
More than 180 degrees, sir.
Okay. So in that case, what will be your plan in case you find that this is not resectable?
Go ahead try to improve the relieve the symptoms, sir. Quality of life, improvement of quality of life.
Your patient is there with you. You have taken history and examination. We are talking about this patient only. You find after CT scan there are findings that patient this can may not be resected. So what you are going to do?
Chemotherapy.
You want to palliate something?
Yes, sir. Palliative of symptoms, sir.
What palliation?
If there is for
Patient is not having gastric outlet obstruction.
yes.
Patient
For
is
the biliary, the pathology obstruction, sir, I try to go for ERCP stenting, sir.
so you are going for biliary drainage. Okay. Yeah. If it comes out to be resectable, then what's your plan?
After optimizing the patient, sir, go for staging laparoscopy to confirm for peritoneal.
Optimization means what you are going to give, accept all these things. Are you going to give vitamin K to this patient?
Yes, sir.
In case the INR report is normal, then also you are going to give vitamin K.
Yes.
It's better to give now.
Yes, still.
So if resect, then what you are going to do?
Go ahead with staging laparoscopy, sir, to see for peritoneal mets. And then if it is clear, sir, then we'll go for pylorus preserving pancreaticoduodenectomy.
So is there any other question? Because we have crossed the time. Can I give sir?
Okay, I'll just ask you one small thing. What is a teardrop sign? It is involvement of the superior mesenteric vein, which looks like a teardrop on axial view in a CT scan. Okay, that's a sign of unresectability.
Yes.
Okay.
Then
Can you
touching about, sorry, sir, the touching about this thing, the role, somebody is asked in the chat for any role for a pre-operative biopsy. Yes.
Yes.
Any
Okay.
senior,
When
I think we should
when when is a biopsy indicated?
Yes.
Dr. Karanisa?
Yes, sir. If it is
When
suspecting ampullary variant, sir, we can go for ampullary biopsy, sir, or we can go for carcinoma head of the pancreas to endoscopic ultrasonographic biopsy.
no, okay. I mean, is a biopsy indicated in these conditions?
Yes.
Generally,
Resectable disease.
no, sir.
Is indicated
Yes.
unresectable.
Unresectable.
Before you start any chemo or
So chemotherapy.
immunotherapy, you have to because you can't start it without a tissue biopsy, tissue diagnosis. Okay, that's why. Okay,
Well,
okay.
yes, we can move on to next question. Yes.
Okay, thank you. Dr. Karunisa, do you want to ask anything? Any doubts?
No, sir.
Okay, thank you so much.
Thank
Dr.
you, sir.
Kenneth, sir, you can log off Dr. Karunisa, but hang on for the next case.
Okay. Thank you, sir.
Thank you, Dr. Kairunisha. And esteemed faculty, we have the honor of having Dr. Sairam Subramaniam. He's a senior vascular surgeon in Chennai, and he's a good colleague of mine as well. He'll be helping out for the vascular case. Faculty, stay back, and I request Dr. Arjun to introduce yourself, your unit chief, head of the department, and start your presentation. Good luck to you. Thank you, Dr. Kaironisa. Stay for the second case discussion also.
Good evening, everyone. Am I audible, sir?
Yeah, please go ahead.
Yeah,
Good
perfectly
evening,
audible.
everyone. I'm here to present a case on varicose vein. So I am Dr. Arjun Prabhu, finally postgraduate from Tirchi SR Medical College. So my head of department is Professor Dr. P. Karthik sir, and my unit chief is Professor Dr. S. Padma madam. And I also thank Dr. Karnagaran sir. So the chief complaint of the patient. So Mrs. Halagammal, 50-year female from Madurai, a farmer by occupation, came to OPD with complaints of dilated veins over right lower limb for past 3 years. So history of presenting illness. Patient was apparently normal before 3 years, after which she developed dilated veins in the right lower limb, insidious in onset, initially over calf region, and progress gradually to the thigh, becomes more prominent on standing and less prominent on lying down. History of pain in the right leg for the 1 month, which was dull aching in type or medial aspect of the right leg and increases towards the end of the day. And history of itching present over the ankle region. No history of night cramps. No history of skin discoloration. No history of ulceration. No history of constipation. No history of swelling in the lower limb and abdomen. No history of fever. No history of chronic cough. No history of constipation. No history of abdomen distension. So past history. She's not a known case of diabetic mellitus, hypertension, coronary artery disease, bronchial asthma, epilepsy, thyroid disorder, and personal history. Patient consumes mixed diet, altered sleep pattern present, not an alcoholic or smoker. Surgical history, no history of previous surgeries in the past. Family history, no relevant family history. Menstrual history, she attained menopause age of 45 years. Obstetric history, she's a para 2 live one with abortion one with all normal vaginal delivery. No history of sterilization. No history of intake of oral contraceptive pills. Allergic history, not known, allergic to food or drugs. And drug history, no history of intake of drugs for any illness. Treatment history, no history of treatment taken for any illness. So summary of my case, 50-year female, farmer by occupation, complaints of dilated veins of the right lower limb for past 3 years with dull aching type.
Okay, Dr. Arjun, let's go to your first slide.
Without any ulcer. So I like to general examination. Yes, sir.
Hang on, Dr. Arjun. Hang on. Let's go to your first slide.
Yes, sir.
Okay. No. Next slide. No, I mean, taking a name is not important and shouldn't be
Okay,
taken, right?
Okay, sir.
Okay, for 3 years. Next slide. So it started over the calf and progressed to the
Thigh
thigh.
regions.
Right, okay. This is on the right lower limb. There's no pain for 1 month, after which history of pain, right, okay. Itching, no night cramps. What do you mean by night cramps?
The night cramps, sometimes the patient develop night cramps, sir. Even due to DVT also there have been cramps over the legs, sir.
Do they? I mean, suppose there's history of night cramps. What does that tell you? Suppose there's pain at night. What does that tell you?
Yes, sir.
Over the night cramps where? Over the ankle or over the thigh? Over the
Of the
calf?
calf region, sir.
Okay, so what does that tell you?
Some muscle fatigueness, sir. Deposition of substance P.
That's in peripheral vascular disease.
Yes, sir.
How is night cramps associated here? Okay, in a patient of varicose veins, when do the pain come? When does the pain come?
So towards the end of the day, the patient develops pain, sir,
Why does that happen?
because of pooling of the blood over the lower limb, sir. Due to
So there is,
gravity,
right, there's edema there, there's swelling there,
yes, sir.
right? So there's decreased circulation, the blood is pooling there, that's why.
Yes, sir.
So night cramps is, when in such patients, will the pain become less on sleeping or will it become more on sleeping?
Increases on sleeping, sir.
It will increase on sleeping. You just said that the pain is because of pooling of blood.
Yes, sir. So it reduces on sleeping, lying down, sir.
Yeah, it should. They usually get relief.
Yes, sir.
Right. Okay, next slide. Dr. Arjun, you should show
Yes.
you should either go through your slide again. You just can't put it once and then come put it up here, right? You should
Okay,
review
sir.
your slides.
Yes, sir. Sorry, sir.
Right. Because there's duplication, history of abdominal distension, swelling. What is the difference between swelling in lower limb and abdominal distension?
The swelling in the lower limb means edema, sir. In abdomen to rule out any tumors or ascites, sir.
So an abdominal distension, swelling in abdomen. Look, these are terms which are just thrown out in there without any meaning.
Yes.
Okay.
Okay, sir.
Next. Past history, just say it as medical history rather than past history.
Okay, sir.
What do you mean an alcoholic? Who's an alcoholic?
So consumes alcohol.
Does consuming alcohol makes someone an alcoholic?
No, it's a chronic consumption of alcohols.
Right. No, it is dependence. So if you don't
Okay,
get
sir.
alcohol, they start getting withdrawal symptoms. That's an alcoholic.
Okay.
Right. So consumption of alcohol.
Okay, sir.
Right. Next slide, please. Which previous surgeries are you looking for?
So first to rule out recurrence, sir. Any surgery related to varicose vein, I have to rule out that surgery, sir.
Any other surgeries?
Any surgery in abdomen, sir.
What kind of surgery in abdomen which will lead to swelling of the
Sir,
lower
any
limb?
surgery, if there is a chronic immobilization, patient will develop a DVT, sir. I mean, that may also give us a risk factor for varicose vein.
Okay, one would be DVT. Okay, because of surgeries prolonged. Any surgery in the abdomen? What surgery are you looking for?
Any pelvic surgery, sir.
Okay. Pelvic surgeries or any surgery of the kidney where the IVC could be damaged.
Okay, sir.
Family history. Which varicose veins conditions run in the family?
Sir, but it's uncommon in family, sir, but
It's uncommon, right?
yes, it's uncommon. Sir.
Do you know of a congenital type of varicose veins?
It's a Klippel-Trenaunay syndrome.
Right. What is that?
So there is hypertrophy of the unilateral limb with varicose vein with AV fistula formation.
Very good. Okay. Next slide,
And Port
please.
Weber. Yes.
That's fine. Next slide. Menstrual history. Okay. Okay. Next slide. Next. Okay. So what do you think by, next slide, please. Yeah. So what's your provisional diagnosis by history?
So by history, there is a dilated veins over the right lower limb, sir. So most my provisional diagnosis is varicose veins, sir, of the right lower limb.
Anything else?
Varicose vein.
Anything else?
So
Sorry,
varicose
please.
vein, it is a dilated, elongated, tortuous, superficial veins, sir.
How
More
much
than 3
dilation?
millimeter. Sir, more
How
than
much
3
dilatation?
millimeters, sir.
No, 4 millimeters.
Okay, sir.
That's what the book said.
Spider vein?
Sir?
What is a spider vein?
So spider vein, it is a 1 to 3 millimeter dilatation, sir, of superficial veins.
What is a reticular vein?
Reticular vein less than 1 millimeter.
Okay, I'll just ask you one question. What is the difference between reticular vein and telangiectasia? I know it's a tough
Sir,
question. Reticular veins are subdermal,
Okay, sir.
right? While telangiectasia is intradermal.
Okay, sir.
So please.
Yeah. So I just wanted to take you back to the first slide where you were talking about pain. So why do you think we get pain? Why does a patient with varicose vein get pain? What are the causes?
So because during the daytime, because of gravitation, there is a pull of there is pulling of the blood over the lower limbs, sir. So patient is, instead of pain, they complain of discomfort.
Okay, so that's the first thing when the varicose vein is uncomplicated.
Yes,
It's
sir.
not causing any further complications. Then
Yes, sir.
you can develop pooling that causes distension, and that causes the heaviness and pain.
Yes, sir.
So that is what you get typically at the end of the day.
End of the day, sir. And release on lying down, sir.
Correct. Yeah. So this same pooling can also cause muscle irritation, and that can cause nocturnal cramps.
Okay, sir.
The cause of nocturnal cramps, again, it happens in uncomplicated varicose veins.
Okay, sir.
Okay? Now, if the patient starts developing complications, especially
Yes, sir.
skin inflammation, what are the complications that you know?
So the complications related to varicose vein, they are like hemorrhage, sir. Then phlebitis, like superficial thrombophlebitis.
Right. So that can cause pain. Thrombophlebitis.
Yes, sir. It will cause pain, sir.
Right. So what kind of pain will that be?
So it is a superficial type of pain, sir, with sharp pricking type of pain patient loves.
Right. So that's going to be sharp and it's going to be acute onset. It's going to be
sir.
localized.
Yes, sir.
Okay. What other complications do you know of varicose veins?
Sir, hemorrhage, phlebitis, then calcification of veins.
Calcification.
Yes, sir.
Okay. Anything else?
Sir, then equidus deformity.
Okay. What does it do to the skin? What are the long-term changes of varicose veins?
Pigmentation, eczema, lipodermatosclerosis.
Right. So what is lipodermatosclerosis?
So it is thickening of the fibrous of skin and the subcutaneous tissue, sir.
And why does it happen?
So because of long-standing varicose veins, because of pooling of blood, there will be fibrosis. There will be formation of fibrosis, sir, because of trapment of the leukocyte.
Right. So essentially, it's a state of chronic dermal inflammation.
Yes, sir.
So that inflammation per se can cause a constant pain. That
Okay,
pain is
sir.
different from the pain that you would get with prolonged standing.
Yes, sir.
So that can be a cause for pain in someone who's got complications.
Okay, sir.
All right. So
Yes,
those
sir.
are the main three causes. Yeah?
Yes,
Apart
sir.
from that, someone develops an ulcer, obviously they can develop pain because of that.
Okay, sir.
All that comes under complicated varicose vein.
Yes, sir.
All right. And then there was something about, so overall in your past history, the main thing to rule out is a history of DVT.
Yes,
So
sir.
you've got to be specific about that.
Okay, sir.
And then there was something about coronaries. So how does coronary artery disease impact varicose vein?
Sir, so DVT, there will be chance of emboli, sir.
How is coronary artery disease related to DVT?
So there is no direct relation, sir. Just for sake of fitness of surgery, we have to rule out, sir.
Is there anything in the heart which can cause DVT? Which can
Yes,
cause
sir, any emboli, sir.
varicose vein? Sorry.
Intramural thrombus formation, no.
No, anything
Or
in the
atrial
heart which can lead to varicose veins?
Oh, sorry, sir.
So if the patient has got a tricuspid regurgitation,
Okay, sir.
Intense back pressure on the IVC,
Okay, sir.
that is one of the causes for developing varicose veins.
Okay, sir.
Anyone who has a cardiac condition which can cause tricuspid regurgitation.
Okay, sir.
Anybody with a pulmonary hypertension.
Okay, sir.
That can lead to TR and then varicose veins, right?
Yes, sir.
So if you're looking at a cardiac history, you must look at any condition which can cause a right heart hypertension.
Okay, sir.
All right.
Yes, sir.
Why you took the history of chronic cough and constipation? I don't.
So because for formation of varicose veins, sir, thoracic and abdominal pressure are important, sir. So if there is increase in the intrathoracic or abdominal pressure, it is one of the precipitating factor for varicose veins. So in chronic cough like COPD or patient constipation, there will be increase in the intrathoracic or intra-abdominal pressure. This leads to varicose veins. So to rule out that, I asked that questions.
Okay, okay.
Dr. Arjun,
Yes, sir.
you tailored your history to a diagnosis of varicose veins.
Yes, sir.
See, when you are asking about pain in a pain in a leg.
Okay, sir.
Okay. So what is its relation to walking? You did not ask about it.
Yes, sir.
Okay. So you've already you've tailored your this thing. As a postgraduate student, you should be inquisitive.
Okay,
You
sir.
have to rule out other pathology.
Okay,
Okay,
sir.
50-year-old maybe farmer who has a long standing, only 3 years onset. Okay, tobacco, use of tobacco. Okay, and
Yes,
all
sir.
that. See, the relation to walking is important, and what time of the day it is. Those things are also important to rule
Okay,
out
sir.
arterial and neurogenic.
Arterial venous. Yes, sir.
Okay, okay.
Okay, sir.
Otherwise, and you told night cramps are there, and night cramps are not there in your summary. So that's a difference. So
Yes, sir.
be careful while noting down things.
Okay, sir.
Yeah, please go ahead with the examination.
Yes, sir. So general examination, the patient is conscious, oriented, ECOG score is 0, that is able to do all works by herself, moderately built and nourished, no pillar, not ectric, no cyanosis, no clubbing, no generous lymphadenopathy, and no pedal edema. So vitals, pulse 86 beats per minute, blood pressure 120 by 80 mmHg, respiratory 17 breaths per minute, temperature 98 degree Fahrenheit. So local examination of right lower. After explaining the procedure and getting consent from the patient, she was exposed from umbilicus to the foot and examined in the standing position. So on inspection, dilated and tortuous vein seen over the medial aspect of the thigh, behind the knee and medial and posterior aspect of the right leg. No hyperpigmentation, no edema, no ulcerations, no redness, no loss of hair, no brittle nails, no scars, no deformity, and Morris's cough impulse is absent and left lower limb appears to be normal. This is the image of the patient. On palpation, there is no warmth, no tenderness. Inspectory findings are confirmed. Brody Tendelbeck test. Test 1 is positive, so it suggests of saphenofemoral incompetence. Test 2 is also positive, suggests of perforator incompetence. Then multiple tourniquet test, it is positive and perforator incompetence of the thigh, below knee and above ankles are noted. Then Fagan's test, multiple defects were felt on the right lower limb, 5, 10, and 15 cm above the medial malleolus. And Morris's cough impulse is absent. On Schwartz test, impulse not felt in the saphenofemoral junction. No cough muscle tenderness, no bilateral inguinal lymph node involvement. Circumference of the cough muscle measured 10 cm below the tibial tuberosity is 36 cm on both legs. Peripheral pulse examination felt equally in both limbs. Left lower limb is normal on examination. So other system examination, CVS S1, S2 is here, no murmur. RS, normal vesicular breath sounds, no added sound. Perabdomen is soft, non-tender, no organomegaly, no palpable mass per abdomen. Central nervous system, no focal neurological deficit. So summary, 50-year female, farmer by occupation, complaints of dilated veins of right lower limb for past 3 years with a dull aching pain of the right leg with itching. On examination, dilated tortuous veins noted over medial aspect of the thigh, behind the knee, medial and posterior aspect of the right leg with saphenofemoral junction incompetence, with mid-thigh, knee, and leg perforator incompetence on right lower limb. So it is a case of primary varicose vein of right lower limb involving great saphenous vein with saphenofemoral junction incompetence and mid-thigh, knee and leg perforator incompetence without any complication. So CEAP classes C2, etiology is primary and anatomic superficial perforator both, and pathophysiology is reflex. So C2, EP, ASP and PR.
Okay, Dr. Arjun, let's go to your first slide of our examination. There's no pedal edema.
No edema, sir.
Okay, what kind of edema are you looking for? What kind of edema would you expect in this patient?
So there will be pitting edema noted around the ankles.
What is the difference between pitting edema and non-pitting edema?
So pitting edema, while we palpate, when we give the pressure and we release, there will be a pit will be formed, sir. So it can be differentiated from the varicose vein or lymphedema due to other causes.
Okay. No, first tell me the difference between pitting and non-pitting.
So pitting edema, at the level of medial malleus, we should give some pressure and.
No, that's fine. You find a pit.
Yes,
it doesn't. And non-pitting, what's that?
So non-pitting, it can be due to other systemic causes.
Is it? So in cardiac failure or in hepatic failure, you find non-pitting edema.
So we have pitting edema only.
So what are the cause of non-pitting edema?
So DVT.
When there's chronic pedal edema, there's inflammation, and there's a lot of fibrosis.
Yes, sir.
So you'll get non-pitting.
Okay.
The fluid cannot be displaced from one place to another because of fibrosis.
Okay, sir.
Right?
Yes, sir.
So what is Stemmer's sign?
So Stemmer's sign will not be able to pinch the skin at the level of the between the digits.
Right.
Sir.
So that is in non-pitting. Right. Okay. Next slide, please. Okay, next slide. Don't do this exposed from umbilicus to foot and examined in standing position.
Okay, sir.
It's very, 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 what do you call it? Demeaning. Next slide, please. Look, you've got to assess both the limbs first before going to the affected limb.
Okay, sir.
You got to compare both the limbs.
Right? Okay, sir.
And that is, you have to see, look, by history and examination, you have to rule out a peripheral vascular disease and an arterial disease from a venous disease. You have to distinguish that way, right?
Yes, sir.
You have to compare the two limbs. Now, what have you compared the two limbs?
Yes, sir.
What do you compare?
The left leg is normal, sir.
No, what do you mean by normal?
So there is no dilated veins or ulceration, no pigmentation, sir.
Right. So you have to look for the length, the girth.
Yes, sir.
The skin, the integumentary system of both the things. Then come down to the visual veins. Right?
Yes.
Medial aspect behind the knee, posterior aspect of the thigh. No hyperpigmentation where? Where are you looking for all this? Look, you have clubbed both the arterial findings and the venous findings together.
Okay, sir.
Right? You got to keep them away.
Yes, sir.
You tell us about the arterial findings that are absent, and then tell us about the venous findings which are present.
Okay, sir.
So where are you looking for this hyperpigmentation?
Hyperpigmentation around the ankles and the legs, sir.
The gaiters area. Why is it that area is involved?
So there is in gaiters area there is a more of perforators are there, sir.
Is that so? There are no perforators on the lateral side.
Compared to lateral medial side, there is more perforators, sir.
No, you got the whole. You have great saphenous vein running on the medial side.
Yes,
isn't it? So if the walls are involved, there's maximum pressure on the gaiters area.
Okay.
That's on the medial malleus, and that's where all the story begins.
Yes, sir.
Right. What deformity you're looking for?
So equinus deformity, sir.
Why do you get a equinus
So if
deformity?
there is ulceration because of pain, patient will walk with the pain, sir. Then develops, it will lead to equinus deformity, sir.
So slowly there's fibrosis, right?
Yes, sir.
There's inflammation and fibrosis.
Yes, sir.
Morris's Culffe pulse, what is that?
So Morris's cough impulse, we have to look at the saphenofemoral junction, sir. If there is a
Mhm.
saphenofemoral junction incompetence, there will be cough impulse seen, sir.
What is that known as?
So saphenovirus.
Right. So the saphenous opening is in what layer of the lower limb? Where
So the deep
is this
plate.
opening?
So between the superficial and the deep fascia, sir. Cribriform
What is this
fascia.
fascia called? What is this
Cribriform
fascia
fascia.
called?
Cribriform fascia.
It's the fascia lata, cribriform
Okay, sir.
fascia.
Yes, sir.
Cribriform fascia is the one which covers the
Yes, sir.
opening, isn't it?
Okay, sir.
Right. Okay, next slide, please. Okay, next slide. Next. Okay. So which is the first test you do?
The first
Please
broad
don't
test.
write inspectory findings are confirmed.
Okay, sir.
Right? Nothing like you're confirming. What inspectory findings are you confirming?
So the location of the varicose vein.
So by palpation, you confirm that what you've seen is right.
Okay.
Don't mention that. What is the first test to be done in a case of varicose veins?
So Trendelenburg procedure, Broad Trendelenburg test.
What is the importance of Brody-Trendelenburg test?
So to find out the saphenofemoral junction incompetence and perfect incompetence.
Right. So before that, what is the absolute contraindication for any intervention in varicose veins?
So to rule out DVT, so then only we should do the test.
So if you do a test for DVT and it's positive, all other tests are redundant.
No, sir, we should not do, sir.
Hmm?
If the DVT is present, then we should not do any of the tests, sir.
Right. So yeah, the first test to be done is
Hoffman's
what
test,
is the test for DVT?
Hoffman test and Moses. Hoffman test and Hoffman's test and Moses.
No, you don't have to do these tests.
Okay, sir.
How do you diagnose DVT clinically? We've
So
got through the
muscle
history. That's
tenderness,
fine.
sir. Calf muscle tenderness.
That's it.
Patient will have severe pain and edema of the lower limb, sir.
The limb would be swollen. It would be red. It
Yes,
would be hot. Right? And
Yes,
there'll be tenderness. And any test for that? Any other tests? What is Perthes test?
So Perthes test we can do. We can diagnose the DVT with Perthes test, sir. There are two types of Perthes, sir. One is old Perthes and another one is modified Perthes test, sir.
So what's the difference between the two?
So in the first one, the patient will only see, we can only get the feeling of pain, sir. But in the second test, that is a modified Perthes test, we can see the increase in the size of the varicose vein, sir.
Why? What was the modification?
So in modification, there is we are not using the crib bandage, sir. Only at the saphenofemoral junction, we'll use a
An
tourniquet,
Eschmark bandage was not. So if you
Yes.
just put an Eschmark, you can't see the veins dilating.
Veins dilators.
Right? So that's why it was done away with. Right. Okay. Now let's come to your so your Perthes is negative.
Yes, sir.
Right. So next test would be
Brody-Trendelenburg
1 and 2.
test.
How do you do that?
So in Trendelenburg test 1, sir, first we'll make the we should ask the patient to lie down, sir, and we should elevate the limb and we should milk out the blood, milk out the veins, sir. Then at the level of just below the saphenofemoral junction, tourniquet is tight and patient has to stand up, sir.
Where is the saphenofemoral junction exactly? What's the surface
So 4
margin?
centimeters below and lateral to the pubic tubercles.
Right. Okay. So you tie a tourniquet. Then what?
Yes, sir. Then I'll ask the patient to stand and I'll remove the tourniquet, sir.
You remove the tourniquet?
Yes, sir, for test 1, sir.
Do you? No, when you make the patient stand, what do you do?
So I'll wait for 1 minute and I'll then remove, sir.
And wait for 1 minute and do what? What
I'll
are you doing
remove
while waiting for 1 minute?
To rule out the perfect incompetence.
you'll see whether the vein is filling from below upwards,
Yes, sir.
right?
Okay, sir.
Won't you?
Yes, sir.
Yeah. So what does that tell you?
So if the veins fill from below upwards, it means a perfect incompetence, sir.
Exactly.
If the
Then
veins
what do
fill
you
from
do?
above downwards, it is saphenofemoral
Then,
incompetence.
then what do? You made the patient stand,
Then I'll remove the tourniquet, sir.
and then what do you see?
I'll see the filling of the veins, sir, whether it is below upwards or above
Filling of the veins
downwards.
from where to where?
From the deep to the superficial.
From above downwards.
Yes, sir.
From above downwards, right?
Okay, sir.
Right. What about 2?
So in 2, we should not remove the tourniquet, sir, and we should see whether it's filling from below upwards.
Okay. Next slide. So what's the difference between multiple tourniquet test and Trendelenburg 2?
So in Trendelenburg 2, only we can say there is perfect incompetence is there or not. But in multiple tourniquet tests, we can get the exact position of the perforator, sir. Whether it's mid thigh or knee level or below knee perforators.
Okay. Okay. So anyone else?
No,
Okay.
please go ahead.
Multiple tourniquet test. How many tourniquet you apply?
So you have to apply 3 tourniquets, sir.
Where?
So one is below the saphenofemoral junction, one is above the knee, then below knee, sir.
Usually, how many perforators are there below knee?
So below knee, we ankle perforator, there are 3 ankle perforators, sir. Then at the knee level, we have 2 perforators, sir.
No, at least below the knee, there are 3 perforators. So you have to at least apply 2 or 3 tourniquet there.
Okay, sir.
Okay. So one below the saphenofemoral junction,
Yes,
one
sir.
above the knee,
Okay,
and
sir.
2 or 3 below the knee.
Okay, sir.
How do you open the tourniquet when you are carrying out?
No, so we'll not remove the tourniquet, sir. We'll see where the veins are filling, sir.
You do not open the tourniquet when you are doing
No,
the
sir.
multiple tourniquet test?
No, sir. Tourniquets are not removed, sir.
Tourniquets are removed, na? That's what you want to see here.
Okay, sir.
That is the way you will know that which perforator is incompetent.
Okay, sir.
You start removing one by one from below up.
Okay, sir.
Okay, so the lowest one will be opened first, and then you
Yes,
will
sir.
see if there is filling of the veins are there or not.
Okay,
By
sir.
that you can locate that.
Yes, sir.
Okay. Now, in which test, various varicose vein tests, you do not empty the veins. In majority of the tests, you have to empty the veins.
Yes, sir.
In which test you do not empty the veins?
Sir, in Perthes test, we will not empty the veins, sir.
In Perthes test, you do not open them.
Yes, sir.
And then you said the Homan test and all those tests. It is not, you are dealing with acute DVT.
Okay, sir.
Okay, whenever there is a varicose veins are there, it is always
Yes.
a chronic DVT is there.
Okay, sir.
And what is that called as? What is the name of that syndrome called as? When there is a chronic DVT with the varicose veins which are there? Post-phlebitic syndrome.
Okay, sir.
Okay, that is called a post-phlebitic syndrome.
Yes, sir.
So there you do not demonstrate the Homan and those tests. Okay,
Most
that is
tests.
only for the acute DVT.
Okay, sir.
In the chronic DVT, only the diameter of the limb will be increased. So there will be. So if you measure the diameter of the limb, you will find that that is increased.
Okay, sir.
There may be or may not be any tenderness.
Yes, sir.
Okay. So once you find the varicose veins with a swollen limb is there, always
Yes, sir.
suspect that the patient might be having
DVT.
the secondary type of the varicose veins.
Okay, sir.
What are the other causes of secondary veins apart from the DVT?
So any trauma, sir, previous surgery,
Yes.
AV fistula formation.
What did you say?
Say trauma to the veins, then
Yes.
deep vein thrombosis, then
Yes.
AV fistula.
Yes. And any abdominal? Any
Sir?
abdominal tumor can lead to the
Yes, sir. Yes. Abdominal surgery, abdominal tumors.
any pelvic tumor is there. Okay. Any surgery in
sir.
the pelvic region which is there. What is May-Thurner syndrome? Any
So,
idea?
May-Turner system, it is the compression of the left common iliac vein with the right common iliac artery, sir.
Okay.
Causes left side varicose vein.
Yes. Not the varicose veins. It causes the
Thrombus.
thrombosis there. And,
Thrombus, deep vein thrombus on the left side.
and because of that, there can be a secondary varicose veins.
Okay, sir.
Okay.
So, Dr. Arjun, there is
Yes,
one
sir.
test from S. Das which you have missed. Okay, which is
Pratt's
Pratt's test.
Pratt's test.
Yes.
Yes, sir.
Can you describe what?
So in Pratt's test, sir, after emptying the vein, sir, we have to tie the tourniquet just below the saphenofemoral junction.
We use an S mark.
Sir. So first
Okay.
tourniquet is tied, sir.
Yes, yes.
Then S mark bandage is tied from the toe to the mid thigh, sir.
Mm-hmm.
Then we should remove the S mark bandage, and from above downwards, we should tie the. Again, we should start tying the S mark bandage.
Mm-hmm.
We'll look for the bulging of veins.
Okay. Yes. And it is for the perforators.
Perfect incompetence.
Yes, yes. It probably before the advent of Doppler, this was a pre-operative guide
Okay.
for the location of perforators. Okay. Yes.
Yes, sir.
So Arjun, just a couple of things to add. The initial clinical photograph you showed,
Yes, sir.
you can just go back to that. So the skin over the vein, why is that black and it seems to be a little indurated?
So clinically, it's not indurated, sir. Palpating is not indurated, sir.
Why is it black? Why is there pigmentation in that area?
Yes, sir. Because of hemosiderin deposition can have taken
Why
place.
should hemosiderin deposit there? Hemosiderin deposits and all those changes happen in the gaiter area,
Yes, sir.
not on the varicosity itself.
Even due to phlebitis, there will be.
Yeah, so when there is this kind of picture, you must think of TSC, superficial vein thrombosis.
Yes, sir.
Okay. Then you were talking about calf circumference, and I think sir has already told you why. So why do you measure calf circumference?
So to rule out arterial disease, sir.
Calf circumference.
Sir.
Limb girth. Why do you measure limb girth?
So in arterial disease, there is a decrease in the calf circumference, sir. There will be atrophy of the muscles, sir.
Okay, agreed. But why? What exactly are you looking at in this case of varicose vein? Why are you comparing limb girths?
So Klippel-Trenaunay syndrome.
That's not sir mentioned, no?
So even Klippel-Trenaunay syndrome, there will be hypertrophy of the calf muscles.
Okay, one of the causes. What is the other common cause for secondary varicose vein?
Sir, any abdominal tumor, sir. DVT.
DVT. So any post-thrombotic
syndrome.
That the limb will be swollen compared to the opposite side. That's a surrogate sign of a old DVT.
Okay, sir.
And then you were mentioning about pulse palpation. Why is that important?
So pulse for completion sake, but to rule out arterial disease.
Nothing is done for completion sake. Pulse palpation is extremely important in a patient with varicose veins, and we need to know why. Why do you think it's important?
So AV fistula we have to rule out, sir.
Will palpating a pulse rule out AV fistula?
No, sir.
Now you're putting yourself into further trouble. If there is a AV fistula, what will happen to the pulse?
Missionary murmur.
That's on the AV fistula. What happens to the pulse in the foot?
It reduces. It will be feeble, sir.
It can reduce if there is an ischemic steel. But anyway, let's not digress.
Yes,
why do you need to palpate pulses in a patient with varicose veins?
Yeah.
So there are two things. One is there could be a concomitant arteriovenous ulcer.
Okay, sir.
With someone who's got complicated varicose vein,
yes, sir.
Ulcer, there can be what is called a concomitant arteriovenous ulcer.
Okay, sir.
There you have to treat the arterial pathology first.
Yes, sir.
The second more important thing is what is the first treatment that you're going to give these patients? We're going to put them on some kind of compression, isn't it?
Yes, sir.
Compression is contraindicated if there is
In
significant
arterial disease.
peripheral arterial disease.
Yes.
Okay, so that is the main reason why you must look for peripheral arterial disease in these patients. Right.
Yes, sir.
Yeah. So the rest I'm okay. Anyone else? Please go on then.
Yes, sir. So the diagnosis case of primary varicose vein of right lower limb involving great saphenous vein with saphenofemoral junction incompetence, mid-thigh, knee and leg perfect incompetence with no complication. So CAP is C2 EP with A superficial perfecta and PR. So first I'll do investigation to confirm my diagnosis. So first investigation I'll do is venous duplex ultrasound imaging of both lower limb with ultrasound abdomen and pelvis. Sir, in this patient, it was given as a saphenofemoral junction incompetence with no evidence of any deep vein thrombosis, and multiple perfect incompetence are noted in mid-thigh and below knee and level. Then I'll do other investigations for favor of surgeries. So I'll do hemoglobin, total counts, then chest X-ray, then ECG, then serology, blood grouping, and coagulation profile.
Okay, so when you're looking at a venous Doppler for a
Yes,
patient
sir.
with varicose veins,
Yes, sir.
what all information do you want to get from that?
So we'll look for first we'll rule out the deep vein thrombosis, sir, by looking for the compressibility of the veins, sir.
Okay. What are the
Then
three
I'll look for
types
the
of veins
reflex.
in the leg?
Sir,
What are the 3 types of veins in the legs?
so we have superficial, deep, and the perforators.
So each of them, you need to look at what?
For compressibility, vein thickness of the vein.
You need to look at obstruction and you
Yes,
need
sir.
to look at reflux
Okay, sir.
in all 3 of them.
Yes, sir.
So superficial vein is reflux, superficial vein
Yes,
is
sir.
obstruction. Same way
Yes,
with
sir.
deep veins. You
Okay,
need to
sir.
look at obstruction and you also need to look at deep venous reflux.
Deep vein thrombosis.
Deep venous reflux. So
Yes,
deep
sir.
venous thrombosis is a blood clot within the deep vein.
Yes,
That can
sir.
happen at any point of time.
Okay, sir.
An old DVT that will cause obstruction, that can also cause damage to the deep vein valves, and that
Okay,
can
sir.
cause deep vein reflux.
Yes, sir.
Okay, so both of these can cause varicose veins.
Yes, sir.
All right, so a Doppler must look at deep venous obstruction as well as deep venous reflux.
Reflex.
And then you must also look at perforator reflux.
Okay, sir.
Okay. So ideally, what a Doppler should do is to get the patient to stand up. Reflux is always assessed
Valsalva manner.
when the patient is standing. Yeah.
Okay, sir.
And they must do what is called a vein
Valsalva.
mapping.
Sir?
They must do what is called a vein mapping.
Okay, sir.
Which basically maps the entire reflux pathways of the leg.
Okay, sir.
Right. So, Valsalva maneuver is one way to identify reflux.
Okay, sir.
Other way is what we call calf compression and release.
Yes, sir.
Squeeze the calf for a few seconds and then release abruptly.
Yes, sir.
Okay, so that is the more objective way of identifying reflux when you're doing
Okay,
the
sir.
Doppler. Okay.
Yes, sir.
So venous Doppler is the single most important investigation. So
Yes,
the
sir.
idea is first to identify the source of reflux, and
Okay,
then
sir.
to look to see if it's a superficial venous problem, or if it's
Or
an
a deep-
isolated perforator problem, or if it's a deep vein problem.
Yes, sir.
So if there is a deep vein pathology, that needs further investigation.
Okay, sir.
All right. Okay.
Yes, sir. Then I'll also do ultrasound abdomen.
Okay, go on. Yeah.
No, will you do a Doppler study or will you do the ultrasound?
The Doppler study, sir.
Not the ultrasound?
See, in duplex, we have both Doppler and ultrasound, sir. It gives us a B mode ultra.
Yeah, your answer should be duplex scan.
Okay, sir.
Because you have to see for the anatomy as well as the physiology of the circulation.
Okay, sir.
Right. So anatomically, how do you say, or by physiology, how do you say it is a saphenofemoral incompetence is there?
So based on the direction of the reflex, sir.
Yes. How
Then
much?
whether it's deep to the deep or superficial to the deep fascia, sir.
No. How much should be the reversal of the flow to say it is a incompetence?
So should be for more than 5 seconds if it's there.
Yes.
For more than 5 seconds, if there is a reflex, then it is incompetence.
And for the perforator, how much is that? How do you say perforator incompetence?
Perforator more than 10 seconds. Not sure, sir.
Yeah.
Significant reflux, Arjun, is anything more than 500 milliseconds.
Okay, sir.
0.5 seconds.
Yeah, that's right. Yeah.
Okay, sir.
Perforators, some criteria would say 1 second, some criteria would say 0.5 seconds.
Okay, sir.
Right? So why that 0.5 second? Because that's the amount of time, even in normal individuals, it takes 0.5 seconds for the valve to shut.
Okay, sir.
So even normal individuals will have reflux of 500 milliseconds.
Okay, sir.
Quite often you get Doppler reports saying transient reflux. That's
Yes,
actually
sir.
normal.
Okay,
So
sir.
that's the amount of time it takes for the valve to close.
Okay, sir.
So any reflux which is more than 500 milliseconds is deemed significant.
Okay, sir.
That's 0.5 seconds. Yeah.
0.5, sir.
If you want to evaluate the deep veins, what are the various tests you can do?
Clinically, women's Mosses test are done, sir.
No, investigations for the deep veins.
Sir, we can do, even in duplex, we can roll out deep vein thrombosis. Then we can do MR angiography can also be done, sir.
Right. MR venography.
Yes, sir. MR venography.
Venography can be done. Yes. What else?
Then
what is IVUS? No, what is IVUS? IVUS.
Intravenous ultrasound.
Intravascular
ultrasound.
So, that also for the deep veins.
Okay, sir.
So deep veins, you initially your first guide is to do the Doppler, the color Doppler duplex scan. And then if you need to further evaluate, especially the deeper veins in the abdomen,
yes,
then
sir.
you have to do cross-sectional imaging, either by means of CT venogram or MRI venogram.
Okay, sir.
Sometimes we tend to do puncture venogram. So either there's something called ascending venogram and something called descending venogram. Okay. So sometimes you need to do that, but the gold standard test for diagnosing a deep vein obstruction, especially in the abdomen, is the intravascular ultrasound.
Okay, sir.
So what do you plan in your patient? What is your planning?
So for this patient, first, so conservative management, we can go with the lifestyle modifications, sir. So we should ask the patient to avoid long standing and limb elevation, and exercise can be done, sir. Then elastic compressors, talking of grade 2 sets given, sir, which is of 18 to 24 millimeter of mercury. Then pharmacotherapy can also be tried to increase the blood flow, sir. Then surgery we can plan with the saphenofemoral junction incompetence with the with the tender block procedure,
your patient,
sir.
You will try the pentoxypyline here in your patient.
So if patient is symptomatic, we can try.
Any other symptomatic better than this? Pentoxypyline is mainly, if it is only the venous ulcers only.
Okay, sir.
Okay, not for the simple C2 disease.
Okay, sir.
For the C2 disease, what can be used?
So we can use the diazosine can be.
Flavonoids, flavonoids.
Yes, sir. Flavonoids. Okay, sir.
Or calcium dobislate is there.
Yes, sir.
These are drugs which are good for the early disease, no?
Yes. Okay, sir.
So why you want to do a surgery in this patient? What is the reason?
So the patient is having pain and discomfort, sir.
Okay.
So we can go with surgery for these patients.
So if you are working at a good center, if you have to carry out the surgery, what surgery you will do in this patient?
So I can go with the radiofrequency ablation or endovascular ablation, sir.
So why did you write about the left Trendelenburg procedure and stripping of the great saphenous vein? You're writing your first.
So there are some. So if the distance between the vein and the skin is less than 1 centimeter, or in the dilatation of vein is more, so we can go with the surgery rather than the radiofrequency ablations.
Endovenous treatment will be definitely preferred,
Okay, sir.
over the open treatment.
Yes, sir.
Okay, because open treatment has got more complications as compared to the endovenous treatment. Endovenous treatment can be done as an OPD procedure.
Yes, sir.
Day case surgery like that.
Okay, sir.
It can be performed under the local and the tourniquet anesthesia.
Yes, sir.
Tourniquet, tumescent.
Tumescent anesthesia can be given, sir.
What is that?
So tumescent anesthesia will give a lignocaine with mixed with the oral and the adrenaline, sir, with soda bicarbonate, sir.
Why you give the tumescent anesthesia? What is the reason for that?
So tumescent anesthesia, it gives one thing is wide range of anesthesia is given, so wide range of area of anesthesia is given, sir. And there is it increases the distance between the vein and the skin, sir. So it acts as a heat sink and reduces the surrounding injury because of heat.
So which laser is used for that? Any idea about that? Which laser is used for the endovenous ablation?
The CO2 laser is used.
No, CO2 is not done. CO2 is for the cutting.
Okay, sir.
CO2, like if there's a tongue lesion is there, you want
Yes,
to
sir.
cut that, then you will use the CO2 laser.
Okay, sir.
Here you use the diode.
Sir?
You use the diode laser.
Okay, sir.
Okay. And what is the usual frequency of that? Any idea about that? Diode
Sir, for laser ablation, we use 810 to 1470 nanometers.
Yeah, majority of the time it is the 14701. What you said, the 1470.
Okay.
That is the usual type, but it can be higher or it can be lower also.
Okay, sir.
It can go up to even 1920J.
Okay, sir.
What precaution you have to take when you are doing the classical endovenous laser ablation?
So proper anesthesia should be given, sir. Prevention anesthesia should be maintained properly, sir.
Okay.
And proper continuous pullback should be done, sir.
So up to what level you will give the laser?
5 centimeter approximate, 5 centimeter from the saphenophymal junction.
Around 2 centimeters.
Okay, sir.
Around 2 centimeter. And up to what level you do the ablation? Do you do up to the ankle?
So up to ankle it cannot be done, sir.
It is only up to the knee level.
Yes, sir.
Because
next question is why?
below that,
it's not flexible.
Why is suggesting that you don't ablate below the knee?
So it is not flexible, sir.
there is some
It's
nerve
extremely
is there,
flexible.
no?
You can take it
Which
from
nerve is
the
there?
ankle.
Sural nerve is present and saphenous.
No, not the sural nerve.
Saphenous.
For the GSV, it is not the sural nerve.
Saphenous.
Saphenous nerve.
Saphenous nerves.
When you are doing the small saphenous vein, then comes the sural vein there.
Okay, sir.
Sural nerve.
So you said avoid prolonged standing. How are you expecting a farmer to work without standing?
So prolonged standing in a single place we should avoid, sir.
That's going to be quite difficult, isn't it?
Yes,
it's
sir.
very easy for us to say. So the key is to give them compression.
Yes, sir.
And even that is difficult for farmers. So you've got to give them an intermittent compression.
Okay, sir.
Pharmacotherapy is indicated for what?
So for patient with ulcerations,
Right. Those with complication and
can be followed.
those with pain and ulceration,
Okay,
in
sir.
them you can try. But otherwise, for C2 varicose vein, there is no indication for giving any kind of pharmacotherapy.
Okay, sir.
Pentoxifillin, the only indication is if there is a venous ulcer, and
Okay, sir.
that is not a completely proven role, but yes, maybe.
Yes, sir.
So you told us about endovenous laser. What are the other methods of endovenous ablation that you know?
So radiofrequency ablation is present, sir.
Okay, so radiofrequency and
Endovenous laser
laser
ablations.
so both of them work on the principle of, these are called thermal ablation techniques.
Yes, sir.
Both of them basically heat up the vein and
Yes,
damage
sir.
the endothelium. Any other techniques you know of endovenous ablation?
So non-thermal is also available, sir. Like sclerotherapy can be used, sir.
Okay.
So then mechanico-chemical ablation is present, sir.
Mechanico-chemical ablation again uses sclerocells. So
Yes, sir.
it's just a type of sclerotherapy.
Then we can also
Then-
use some adhesive glues can also be used, sir. Cyanoacrylic glue.
Yeah. So NBCA glue is another technique.
Yes, sir.
What is the major difference between the thermal ablation and the non-thermal ablation techniques?
So in non-thermal ablation, there is no need for tumescent anesthesia, sir.
Right. Okay.
Non-thermal technique can be used only for perforators incompetence, not for varicose.
No, that's not true. Glue is indicated for truncal veins as well, both the GSP as well as short saphenous vein. Sclerotherapy can also be done. MOCA can also be done, but the recurrence rates are a little higher.
Okay, sir.
Okay. So you can use all these techniques for all the veins.
Okay, sir.
You know any other thermal way of, apart from the laser and the RFA, any other thermal techniques for doing the ablation? You can use the microwave, you know.
Okay, sir.
Or you can also do the steam sclerotherapy also, steam
Yes, sir.
therapy also, you know. So that is the type of the thermal one.
Okay, sir.
You know what is HIFU, HIFU?
No, sir.
For the treatment of varicose veins?
No, sir.
High frequency ultrasound.
Okay, sir.
So there you do not require any anesthesia, only at that local point you can do the high frequency ultrasound. That also can be
Okay, sir.
one of the techniques which is there.
Yes, sir.
Now, when you do the sclerotherapy, you know which agent is used for that?
Sir, sodium tetradecyl sulfate is used commonly.
Okay. And do you use the liquid one or do you use some other variety? Usually.
Sir, like a foam, sir.
Foam. Okay. How do you make the foam? What is that?
So it is framed by Tesserae technique, sir. By using three-way cannula, by mixing the sclerosant with the airs in 1:4 ratio.
What complications can occur because of sclerotherapy?
So some patients, they get anaphylactic reactions, sir.
Yes.
Then it may also leads to DVT or emboli reactions.
What can happen locally?
So local skin irritation can happen, sir. Local infiltration can also cause
Pigmentation. Right?
Yes, sir.
Pigmentation is one of the important side effect of that.
Okay.
Right? In which case you should not do the sclerotherapy. Any contraindication?
So with the DVT, we should not do sclerotherapy, sir.
Yeah, in any treatment which is there, okay, any type of the endovenous treatment or anything should be avoided in a patient who is having the DVT. You know?
Yes, sir.
It is not only the sclerotherapy, but any type of the treatment.
Okay, sir.
Any active treatment, you know? You
Okay,
can go for the conservative treatment for majority of the time.
Yes, sir.
The patient has the patent foramen and ovale is there.
Okay, sir.
In that case, that is a contraindication for carrying out the sclerotherapy.
Okay, sir.
Okay. So any treatment has been done in this patient?
So we have done the tender procedure, sir, with stripping of great saphenous veins. And for perforator, we have done the hook phlebectomy.
What do you understand by tendon operation?
So it is a flush ligation of the great saphenous veins, sir,
Mhm.
with stripping of whole of the great saphenous vein up to the knee joint, sir. Then for perforator, we'll do the hook phlebectomy, sir.
You only do the saphenofemoral ligation in case of tendon operation?
No, sir, saphenofemoral ligation with the stripping of the vein we are doing, sir.
Nothing at the saphenofemoral junction you are doing in a case of tendon operation?
You have to ligate the vein of the saphenofemoral. And all the perforators should be ligated, sir.
Not the perforators. What do you call them?
Tributaries of the great saphenous vein of the GSV should also be ligated, sir.
Yes, you have to tell that, no?
Yes, sir.
Saphenofemoral ligation along with ligation of all the tributaries.
Tributaries.
No?
Yes, sir.
What are the tributaries which are there?
So superficial circumflex iliac, sir. Superficial external parental and deep external parental, sir. And superficial inferior epigastric. All these veins should be ligated, sir.
Any other veins which can be there?
So anterior accessory of great saphenous vein.
Yes. You have to take care of them because that
Yes,
is a. So why does this, after your surgery, what is the cause for recurrence is it? Why does the
So one is improper ligation, sir. Sometimes we'll have ligated on the anterior to great saphenous vein, sir. Then is VEGF, sir. Because of VEGF, there is recurrence.
Yes. Anything else? If there is a recurrent vein is there, you have to always investigate. You have to always see with the deep veins, no?
Okay, sir.
Okay, so you have to always check once there is a recurrence is there.
Yes, sir.
Okay. So if there is a recurrent varicose vein is there, what are the options to you? If the deep veins are okay, what
Yes,
are the
sir.
options to you?
Sir, for recurrence, we can do banding, sir. Now again, for recurrence also, we can do tentative procedure, sir.
It depends upon that what is the cause for the recurrence. You have to find out the cause for that.
Okay, sir.
Okay, but majority of the time, it is the sclerotherapy which is used for the non-truncal because many times it may be non-truncal type of the recurrence may be there.
Okay.
So sclerotherapy is the answer for that, majority
Yes,
of that. Okay, apart from the compression stockings and the medical treatment, sclerotherapy is the main. But if there's a main vein is there, then you have to again take care of that particular vein.
Okay, sir.
Okay. Can you stop Dr. Sairam here?
Yes, sir. I'm good. Yeah.
Dr. Kanagavel? Dr. Nitin, you want to ask anything?
Yeah, we can call it a day, sir.
Yeah.
I think most of the things have been discussed. What at the basic level, the concept of ambulatory venous pressure is important. Yeah, for all process, you should know that. And
Yes.
white cell hypothesis. Yeah, all those are basics. You should know all those things and very well presented the case. But then you should be your mind at you should be broad. You should not probably point to you have a diagnosis, you have dilated veins, and you have pain. It is unusual to have pain in patients with, as Dr. Sairam correctly pointed, it is unusual to have pain.
Okay,
But when you are presenting pain, you should again bring it on by ruling it as a neurogenic or a claudication cause, and then bring it to probably a venous cause.
Okay.
Okay. You should keep a broad mind.
Okay, sir.
Okay. Because if the case is not leaked to you in your exams, probably your results may vary. Okay.
Okay,
So
sir.
you should always go, you should not be biased towards your diagnosis.
Okay, sir.
That is what, as an examiner, we see is more of an approach to the patient, how you approach to a patient. Okay.
Yes, sir.
Thank you. Thank you, Dr. Kanwe. Thank you, other panelists. Shall we call it a day?
Sure. Thank you all for joining this evening. And Arjun, do you have any questions to be clarified, doubts to be clarified?
No, sir.
Okay. Other faculty, Sairam, thank you. Thanks for accepting our invitation in a
Thanks a
short
lot. Thanks
notice
a
for
lot,
joining
Ravi.
us. Nitin sir, also again, we called you only yesterday and you are kind enough to be joining. Harinder Sandhu and other senior faculty here. Hridaynath could not join because he had a liver transplant, it seems. So he excused himself. And I thank Karnagaran sir and Dr. Sridhar sir for providing this students for these classes. Kanna sir, any closing comments, sir?
I think in the case of varicose veins, there are many advances which we have discussed about that. You should know that apart from, so you should not keep your first possibility as a tendon bug operation. Okay. Though it may not be available at your place, the endovenous, but you should, for the purpose, you must say that you will go for the endovenous treatment for that patient.
Okay.
Yeah, rather than keeping as a tendon bug operation. Yeah.
Yes.
Tendon bug operation, if there is a very dilated vein is there, if there's a recurrent vein is there, then in those cases you can think of all that, but not as a first choice. Yeah, no?
Okay.
Okay. Yeah. Dr. Kanagavel, can we close?
Yes, sir. Yes, sir. Thank you, all the faculty, dear students. Thank you for joining us this Friday. Next Friday, we have a case of CA stomach and possibly a case of CA breast. So I was informed like many centers have started their final examination. National board is starting from the 3rd week of this month. So I wish all the students all the very best for the exams. And few of them have called up to inform that they have been successful in their examinations. On behalf of the faculty here, we extend our congratulations for those who have excelled well in the exams. And again, kind reminder, start preparing for the NEET SS. That is very, very important. Don't give a gap. So continue your hard work. And I think we have another 2.5, 3 months to go for the NEET SS entrance examination. So good luck to all of you. And we look forward to meet you in at another Friday postgraduate clinics. Good night, everyone. We call the session a close. Bye-bye.